So welcome to Frontline Nursing, a NurseMinder production that gives you an insider's look into the daily life of nursing from those who are currently working on the front lines. Whether you're considering nursing as a profession, you are studying nursing as a student and wondering what to do, or you're a nurse in transition looking for a new patient population, this show will give you some behind-the-scenes information to help guide your career. Today's episode is all about working in the neonatal intensive care unit. So get those note apps and pens and papers ready because it's going to be another good one. Today on Frontline Nursing, we are joined by Andrea Kobialka. She's been working in the NICU since 2015. Welcome to the show, Andrea.
Thank you.
It's great to have you here, and I'm excited to get into this one because, I have personally experienced the nursing care of my own child when he was in the NICU. So yeah. That was 18 years ago, and lots has changed. So I'm really excited to see LPNs working in there and to hear your experience. So
yes,
let's talk about your first placement and where it was and what it was like for you.
So first job was in postpartum. It was good, I would say, quite scary. I had my preceptor on postpartum, and then I was at a different site on the same, on different unit, but postpartum, same patients and population and everything. So I kind of had my feet wet of what I was getting into. I guess I was very naive to the fact, and being a student, people hold your hand and they want you to pass and they are looking out for your best interest, but I wasn't prepared for how many patients you get and how it's fast, and the turnover rate is fast. And I came from, because I had worked in healthcare aid as a healthcare aide in medicine and in long-term care prior to getting into the LPN program. And so my patients and my history with nursing essentially was people that aren't getting better, people that don't want to help themselves, people that are just going to kind of stay where they are. They're older, this population was more, these are brand new parents. They are sick of staying in the hospital. They want to go home. They want you to know what you're doing, and they want it fast, And so, especially hormonal mothers, they want what they want, and they want it now, or even a little bit ago. So I was very naive in, I've got, 5 moms and 5 babies, or 4 moms and 4 babies, which jumped from, you had, 2 moms and 2 babies working as a student. So it's kind of like a big slap in the face of, holy crap, okay, this changed suddenly and I really have to know what I'm doing now. And not like people aren't helpful, because they are, and people are friendly, but at the end of the day, they have their own patients and they have their own things that they need to worry about. So everyone's kind of out for themselves in a frantic panic of getting everything done, right? So it was definitely hard for me, which I think weeded me out a little bit faster. Because I didn't wait for it to get better. So I lasted from November to December, which it wasn't bad, and I did have good shifts, but I found 90% of my shifts, I was just sinking. I didn't know how to organize my time, and I was really scared, and yeah. So these NICU positions came up at the same site that I was working at, and I applied. There was 6 of them. I applied on all 6 of them. And I got an interview, and I totally bombed that interview, but they hired me still, so that was helpful.
Did they tell you bombed the interview, or do you feel
I feel like I bombed the interview. Maybe they just liked me, or they thought, great, this girl, she seems like she's able to be molded, so we'll pull her in. But it's good I didn't know anything, because this set was actually the first group of LPNs that were allowed at this site. And so a lot of people didn't apply on these postings because they didn't want to be the guinea pigs, essentially, is what I've heard. That might be a different story, but I think that me being naive also helped, because I didn't know what I was getting into, and I didn't know, that we were going to be the first that were going to pave the way through, I guess. So honestly, it wasn't bad, and I'm glad I did it, and I don't have any complaints at all. So yeah, so that was my first actual nursing job.
And you've now been in the NICU since 2015.
Yeah.
It
was January 6, 2016. So yes.
Yeah, so that's amazing. You're obviously enjoying the site, and the
Yes.
standard work. So let's talk about
Yep.
what a typical day looks like for you
Yeah.
in ICU.
So 7:30 our shifts start. You get to the unit, you look at where you are on our little, where your assignment is. Our unit is set up kind of, it's a pretty big unit, but it's got different wings. So there's different areas that you can be in. It's not all open. So it is generally 3 babies to 1 nurse, which is good. So you'll just go to your assignment. It's bedside report. So you'll go to the night nurse or the evening nurse or day nurse or whoever had your babies, and then she'll give you a bedside report. So regardless if the parents are there, you're at the bedside, you're talking about, we go through the cardex of the gestation the baby was born at. They weigh the babies every night, so we're monitoring the weight. They'll let you know what the baby's feeding. They'll let you know if there's any tests that day, the history of the baby, the history of the mom, if this baby has had, if it was really sick or if it wasn't very sick, but we're just gaining weight, things like that. So kind of you establish a plan and what you're supposed to do. And then you get your stuff organized for the day. You set out when your babies, need their things done, when you're going to assess your babies. Depending on where you're working, you can have very sick babies. So you're trying to think about clustering your care. You don't really want to disturb a baby too much if you don't have to, because these are a little bit different in the sense of they are much smaller. So you're trying not to stimulate it as much. Or if this baby is going to be, closer to be going home, you're going to be thinking about discharging. Are the parents ready? Do they need to know anything? Does anything need to be done prior to them going home? Things like that. So yeah, it's every day is different, which is great. Every family member is different, which is also great, or can not also be great too, but that's okay. But yeah, it's essentially you're just kind of looking out for the baby and what needs to be done that day and go from there. So
how did you find that differed from the pre and post? It was pre and postpartum you were doing before, women's?
I was doing postpartum. So it differed a lot because these babies were healthier.
In which place? The NICU or the
postpartum, the babies are way healthier. Like full term, are breathing normally. Parents are ready to go. Sometimes they even had their second or third or fourth baby. They knew what they wanted. They knew that they wanted to breastfeed, or they were automatically not wanting to breastfeed, knew they wanted to give formula. They had it set of, or, you would sit in postpartum and you would breastfeed, or you would help breastfeed for an hour. Or NICU is different in the sense of these babies are not supposed to be born yet. So you are dealing with a lot of prematurity, varying on just a little bit preterm to extremely preterm. So depending on how earlier the babies are born, you kind of establish a thinking process of what weeks involve what developmental stage that baby is going to be in. So I guess the earlier it is, the more complications it's going to have, or a lot more that you're going to have to be doing. So a lot is teaching the parents about what stage that baby is at and kind of just going from there. But it's extremely overwhelming, which I think that we oftentimes forget. So you kind of just have to remind yourself that you're not going to get everything taught completely in one day. And, if you have to take it feed by feed or breastfeed by breastfeed, or one thing at a time, then that's just what you have to do and go from there. So very different.
Can you go back to the first day? I always like to go back to the first day because I know it's always pretty intimidating when you're kind of finally cut loose, no more mentoring, you're like the nurse.
Yeah.
Going to work that day.
Like first buddy shift or first shift completely on my own? Oh,
I know there's always a safety knowing you can call somebody, but when there's a huge transition that happens from the buddy and the mentoring. Even though you may have the full workload, they're still there, and they're sometimes still answering the calls, and they're sometimes still doing your filing, and it's really not some assignment. But now you are the nurse, and there's a huge shift that happens in that 24-hour period from being mentor to being the nurse.
Yes. I think a lot of it is pure panic and fear, because generally when you have a buddy nurse, you're taking over her assignments. So she's kind of staring at you like, okay, what are we going to do? We're having a little pre-briefing session of what's our day going to look like, or I'm going to go see so-and-so because of this, or, and nobody's relying on you anymore. So it's kind of a panic of, oh crap, I actually have to think this through completely on my own. And I mean, you could go to someone and talk it through, but they're probably going to think you're crazy. So you just kind of have to wing it. But my first shift in the NICU, I struggled because parents have questions constantly. And now I'm so used to it, I guess, that you don't even think about it. But I remember going into rooms and just praying to God that parents didn't have questions, because I didn't know how to answer them, and I didn't know what to properly say, or how to word things. And I remember, obviously they're going to ask you questions. And so the amount of times that I would have to leave a room and be like, I'm just going to go ask my colleague and I'll get back to you, or I'm going to go look that up. And you just feel so ridiculous, and you kind of hate yourself a little bit for it. But I guess it's just allowing yourself to be new and learn and just grow through that. It's just the beginning pains of being off on your own and just being new. But I know everyone goes through that. It's just so weird. And I'm very hard on myself, and I can get very awkward very fast. And so if there's two parents that are staring at me and they've got a concern about their baby, and their nurse has no idea how to answer a question, we can take this from 10 to 0 very fast. Like, I don't know. So it was scary, and I felt like it was probably a lot more awkward than it actually was. But yeah, I remember just panicking, being like, please don't ask me questions. Please don't ask me questions, because I have no idea. But I mean, you get through it, and
thankfully they did ask you questions, because you wouldn't be so confident today if they didn't. If every room you walked into, families had 0 questions, you'd still have those fears today.
Oh, for sure. And I mean, I do, because oftentimes parents will ask you questions and you have no idea. That's a thing that is just nursing. But this was, something is just so simple as bottle feeding or something, that we do now that is looked past because it's so routine for us, right? But yeah, I mean, it is good they ask questions, but it was, I don't know, it's scary. It was scary.
Yeah. So when I had my child, I was scared to hold him. I was scared to bathe him. I was scared to feed him. I didn't know what to do, because it was my first one. And so it's not unusual that you would have felt a lot of fears too, just in having those conversations with moms who have questions like, how do I bathe him? Where do I hold his head?
Oh yeah.
What temperature should the water be?
Exactly. So yeah, I've gotten those things covered since, and it's gotten much easier. But yeah, I don't know, every day is different. So
yeah.
Right.
So for those who are listening, they always kind of want to know, a lot of the questions I get are, how hard is it going to be? Or am I going to be able to do this? Am I cut out for this? And I don't know if you have any list of characteristics or behaviors that you think would be really well suited for somebody who would be considering the NICU.
I struggle with it still, and I think I'm coming to the comfortable realization that this is just going to be something that you're going to constantly think. I was so dead set on, after I realized that I wanted to be, just even become a nurse, that was my end goal. That's what I was going to do. And I knew that I wanted to do it, and my mind is made up. I can't see myself ever doing anything else now, but I do have days where I leave work in, you're emotional, or you're frustrated, or somebody said something to you that made you question yourself, or, you're constantly feeling like, and that's just a thing with my confidence and just growing as a person even still, but you constantly feel, you know, am I good enough for this, or why did I get into this, or I'm not good enough for this. And it's a constant, you know, self-doubt talk of everything. But it's I think if you know at the end of the day that you know you wanted to be a nurse and you still want to be here, every day is going to be different. Every day comes with challenges, and to just acknowledge those and just know that you are going to have those challenging days, but you're going to get through them. Good days make up for those bad days, you know. And I think it's just a matter of, you know, acknowledging that you need to continue to keep trying to work hard and do your best. And if you did your best, then that's all you can ask of yourself that day, you know. And sometimes, you know, depending on the kind of day that you're having, your best might not be as good as tomorrow, you know. But it's, yeah, it's a constant. I still struggle, and I think that's a part of nursing. Like, you're taking care of people, you know, at their most vulnerable time of their life, or, you know, nobody expects to be in the NICU. You know, people aren't meaning to be rude to you or mean to you or say bad things to you, but when your hormones are flying everywhere, and, you know, you had this perfect birth plan that you were going to have this baby and it was going to magically come out and magically breastfeed and magically grow up perfectly, and nothing goes according to that plan, then, you know, people are going to take it out on you if you're the first face they see, you know. So it can have challenges, but you just have to show up with the best that you have and continue to try your best, I guess.
Mm-hmm. And that certainly would happen probably more frequently in the NICU than it was in your last role in postpartum, where the plan did go according to, and they are healthy babies. So do you have any strategies that you use or that you've come to develop in terms of interacting with those moms and dads who are feeling a little bit of stress and maybe acting outside of their normal character? How do you interact with them and de-escalate things or bring them back to the focus of the baby?
It's kind of case by case. I still am working on that, I guess. But you kind of have to feel the parents out. Generally, the mom, you know, whether she just had a vaginal delivery or she had a C-section, regardless of what happened, generally the dad will just come over with the baby. So they're kind of taking care of the mom, still in labor and delivery, and we get the baby and the dad will come over. And, you know, oftentimes the dads are extremely emotional, and first dealing with that was even overwhelming for me, because you see these big burly men that are just sobbing at this teeny little baby, and you're secretly panicking because their baby's sick. You also have to kind of be consoling to the dad. So it's this weird dynamic of, I find that almost if I kind of talk them through of even what I'm doing and why we're doing it, and we're just monitoring, it's extremely overwhelming, because a lot of times there will be a neonatologist there. We have a resuscitation nurse who is a recess nurse that will go to all the deliveries or the high-risk deliveries or every C-section. She'll bring the baby over, and so there's extra nursing help in there. There's her, there's a charge nurse, there's doctors, there's residents, everybody. It's a full room.
Yeah.
They're tiny, and so it's overwhelming, and so you even almost get self-conscious that they're listening to you and they're judging you on what you're saying, right? So it's kind of just getting past that, and even just bringing them down to a place of, you're putting leads on your babies just to monitor the vital signs. We're just monitoring vital signs right now. You're putting this probe on their foot to monitor the oxygen saturation, you know, to giving vitamin K. I used to be so nervous to give stupid vitamin K, and it is so ridiculous. And even talking them through what it is and why you're giving it, and, you know, putting it in the thigh, it just, you know, you look back and you have to laugh, but I guess more experience just kind of makes you better.
Absolutely.
And helps you just with your nerves and everything, and just dealing with so many people in so many different situations, I guess, just helps. But just talking through it and kind of bringing them down. And
I think that's a good strategy, focusing on the step-by-step, what are we doing here and now.
mm-hmm.
You know, it gives them a sense of comfort, even just to hear you talking through it. Even if you're panicking, you don't know what the next step is, or what happens if these probes show something wrong, and you might panic with that, but they know that you're actually doing something to assess and monitor, and that the team is there.
Yeah.
Yeah.
So it helps. But
all right. Have you ever been into the delivery room? Just mentioning the delivery room. Have you been able to go in there at all?
I have once recently. They needed a monitor. They had a baby that came out flat, and they needed a portable monitor. And by the time they had called for help, I was actually floating that day. So when we have a float nurse on our unit that will float to all the different areas and help out as needed. So they called from labor and delivery back to our unit, and they asked for a portable monitor. So I went and brought one over. They told me what room the mom was in. So I went over and brought it. And by the time I got there, the baby came up and it was okay. But the like 30 seconds that I got to see was just so cool. It was amazing. So yeah, but it was very short-lived, but that was about it. That's all I did.
So maybe your next career change will be actually with the moms in labor. So I know that when my son went through NICU, we chose to circumcise him. And I don't know if that's still being offered there, but have you had discussions around that, or you've been able to observe circumcision in infants?
No, so that is actually done outside of the hospital system now. So I believe there are very few pediatricians in Edmonton that actually do it now. So they would have to go to their doctor, and then I believe they would get referred to somebody that would do it. But I've never seen it. I've seen the little plastic mold that they place the babies in, and it looks terrible. But
it looks barbaric, doesn't it?
Yeah, and so ridiculous and very not appropriate. But yeah, I haven't seen one get done. I know certain cultures, the minute they have a boy, they're walking through the door asking about circumcision, just as their background. But we just tell them that they have to get in touch with their doctor and get it done outside the hospital. So yeah.
Yeah, I knew it was changing even like almost 19 years ago when my son was born. It was still offered, and you were supposed to pay the physician. They never did bill us, so we got a free circumcision.
That's so interesting.
Yeah, so having been on the postpartum floor and now in the NICU, what are some of the changes in the babies that you're seeing, and how does that affect your care and your assessments?
Well, postpartum babies are they are more, you can stimulate them a lot more, you can bug them a lot more if you have to. They're not sensitive to noise. They're wanting to suck, they're wanting to eat, they have energy, they have body fat. The babies in NICU are very small. Their body does not have a lot of fat on it. A lot of times you'll see the systems kind of, if you get a baby that comes over from labor and delivery that's struggling to breathe, a lot of other areas will kind of fall because of that one system. Like, you'll need respiratory support. So you might see a baby on CPAP. It might be on biphasic, which is just administering, pressures and breaths. And then sometimes they'll even intubate them, depending on what's going on. These kids might be on high flow, depending on whatever they'll need. But you're also kind of monitoring, well, if a baby is on CPAP or biphasic or it's intubated, it's going to need an IV. It's going to need nutrition, because depending on how early it is, it's not going to be eating. So you're going to be giving a TPN through an IV, then you're going to need an IV. You're monitoring blood sugars. You're probably doing blood work by then as well. It's so different. I had a baby the other day. It was a 32 weeker, I believe. So term we say is 37 and above, 36 and above. So 32 weeks, it was really fresh. It had transported from our hospital on a plane. So it was very, very, very stimulated. And these babies can have, negative effects from being transported to different sites because of, all that stimulation. So it was very touchy. And so when when these babies have fluctuations in their vital signs, we call them events. So they're having decreases in their heart rates, they're having decreases in their oxygen saturation, or their respiration rates are very high because they're stressed out. It got to the point on my shift where this kid needed attention, but the more attention that I gave it made it worse. So even standing beside it and watching it was stressing me out. This baby was desatting, and then as a result of the desaturations, if it's going apneic, so if it's having pauses in its breathing, you're obviously going to want to stimulate it because the oxygen that's being administered is not going in thoroughly. So you're giving it stim, which results in it being also more stressed out. So it's kind of this ongoing cycle of stimulate it, but don't stimulate it too much, if that makes sense. So it can be kind of hard, and you're thinking about clustering your care, and you have to organize your care plan of do absolutely everything now so you can only do, like hook up a feed later and don't touch it. You're just going to open its little door and grab its NG tube, check placement, and hook up its tube, It was in an isolette at the time. It had umbilical venous catheter, so it's got a line through its umbilical cord. So it's, you can see it, the site looks great, it's not leaking or anything, so you're monitoring that line that's inserted in its belly, so you can see that it's good.
Is that typical location for IV starts in infants?
What is the typical location?
Is the umbilical one, is that where the access is?
So it's kind of dependent on if it's going to need it for a long time. So if a baby is receiving TPN, ideally it would be better for it to be through a UVC because TPN is hard on veins. So we do have TPN that does run from just IV lines, which, I mean, if the baby is earlier, it will be through its UVC, or through the umbilical cord. But preferable, it would be through a UVC, but a lot of times it is through a PIV. So if it is through a PIV, you're just going to have to monitor the site and, make sure that it doesn't have any agitations or anything from it, because it can be quite hard on veins. But yeah, it's dependent on, I guess, how early the baby's born and how long it's going to have to be on that nutrition for. So.
Now, are you inserting those IVs? Are you doing the baby IVs, or do you have a team that does that?
Well, we do actually do the IVs. So we do our own blood work actually too, which is nice. But yeah, we will insert the IVs, but if they need like an arterial line or they need a PICC line or a UVC inserted, that's obviously a nurse practitioner or a neonatologist or a clinical assistant or resident. So much higher than me, but yeah.
So I know that adults are much easier to put IVs in for me. And I'm just trying to imagine how tiny these IVs are, and how challenging it might be to put them in. But
I feel like if I had to put in an IV in an adult, I would panic, because I look at my own hands and I can't see my veins. I think it's easy. Well, I should say, because I just work there, but it actually is much easier to see a vein and to know where you're putting it. And I mean, you can't really feel anything, but if you run an alcohol swab over a hand, you can clearly see where you want to put it. It's just very superficial. So, I mean, it can be difficult, but a lot of times even too, we'll get emergency calling us, asking us that they need blood work or they'll need an IV inserted. And we'll go down there if we're free. And I look at these hands and I praise my coworkers because they are fat and healthy babies. And I don't think that I would be able to get it. Like, it's easy when you can see, I guess, the veins, but yeah.
Yeah. Oh, that's fascinating. So in terms of working with children, I don't know if that was on your radar. I mean, it sounds like that kind of just came out of fate and opportunity.
Yep.
Was that what you had initially gone into nursing to do, or did you have another thing in mind?
I wanted to be in pediatrics. It still kind of is at the back of my mind.
Yeah.
you know, if I would have went that route. I didn't have the best marks in Norquest when I was taking the LPN program, so I obviously didn't get to go to a PEDS ward. But yeah, NICU kind of just nicely showed up and presented itself, and I luckily got in. So it's great for right now, and I'm so blessed and I'm so happy of where I am. But it still is in the back of my mind, because I mean, I had grown up being a pediatric patient, and so I thought it was the coolest thing ever. I've heard differently from other people that have experience there, but I kind of still secretly want to figure it out for myself. So maybe we'll see later on down the road. I don't know. But for now, this is awesome and I love it. So
what kind of additional training have you had since joining the NICU to position yourself to be the best nurse you can be?
So when we first started, we had awesome education. My clinical educator was with us, I believe, for a month, and it was Monday to Friday. It was like full 8-hour days that was in class.
Okay.
Yeah, so we went through top to bottom of a baby, from assessments to every line that could be inserted, every respiratory device that could be used, every infusion that you could be infusing, every med that you could be possibly, you know, well, not every single med, but a lot of the routine meds that we use, the processes that we do, everything. Again, being the first group of LPNs, I believe they wanted to set us up really, really well so that we did good, because they didn't want us to fall, right? So we did multiple, like NICU is based off of weight a lot. So we did a lot of math, which helped tremendously. And then after our month was up in class, we were buddied, I believe it was for 2 months. So it was a solid 3 months of education and learning beside someone. And then after that, you were on your own. So very, very, very helpful. And then we get lunch and learns constantly on our unit of either, you know, doctors that are teaching something new or reinforcing something that, you know, is, you know, things like respiratory devices on our unit, and dealing with babies that are having events like fluctuations in their vital signs, things like that. So lunch and learns constantly. We need to be certified in NRP, so neonatal resuscitation. So we do that every 2 years. So on top of our CPR yearly, we do NRP, which is good. And then because that's every second year, on the opposite year that you're not doing your NRP, they do recommend that you do take a simulation day. So that's running of essentially with baby, like dolls, dummies, that you're practicing scenarios on, and doing things from delivering a baby to what you would do if you were giving it a little bit of oxygen, to a full code of drawing up epi and this baby's coding. Like they'll run through everything. It's a constant support system. There's always something that you can learn. There's always something that's being sent in an email. So there's multiple opportunities that you can do and be exposed to just continue to better yourself. So
is there anything people can do before they get into that program to better increase their chances of being hired?
Like to work in the NICU? I'm not totally sure. Maybe being around babies. So it probably was a little bit helpful that I did have, even though it was only 2 months of postpartum experience. So I did, even working in my preceptorship, I did have that experience working with, you know, moms and babies and kind of being aware of the process. But I mean, if you don't have any experience and they do get hired, they do an extremely good job of making sure that you know what you're doing. They just changed it recently now that you're going to go to a site-wide orientation. So whatever site you're at in Edmonton, you go, I believe it's at the Royal Alec now. And that is full on basically what we got in a classroom, just in an auditorium. And that's every site that gets hired in the NICU. Whether you're at different hospitals, you're all going to go get the same orientation. And that would run through everything, like we got of assessments to respiratory stuff to math to everything. So I guess if you do get hired, they would train you to kind of brush up on skills before you entered into that workplace, right? So
now I think people get baby experience outside of the hospital too, getting comfortable with holding them and getting to hear their sounds. NICU sounds are very different than full-term sounds.
Yeah.
And I'm happy that I got to know those little sounds. To me, they were the sweetest little sounds ever.
Yeah.
Their little cries sound like little puppy whimpers to me. So really different just in terms of knowing what to listen for. And I'm always curious about listening to the heart rate, because I know you can't palpate it. You got to listen to it. It's chugging along and they're so fast. What are some of your strategies to really hone in on that and count it accurately?
I move my knee or I move my foot in my shoe, and I will just count. I don't know why, but every time you have a stethoscope in your ear, someone has to ask you an important question. So it's a matter of how much time do I have and can I pull the stethoscope out of my ears to listen to you? Or do I need to know this right now and I'll just, listen to you in a minute? But I always have to move. I have to tap my foot or move my knee and just count. But yeah.
That helps you focus on them because they're coming so fast, it's hard to tell them sometimes.
Oh, majorly, especially respiratory noises. And a lot of times babies are grunty. So you're listening to, okay, is this a lung sound or are you actually making a noise right now? Or they'll have a lot of noises in the back of their throat or their nose, or they're wiggling or, ouching or something. And you're listening to either stomach noises, or sometimes you'll, depending on where your stethoscope's placed, are these possibly bowel noises? Like, it just comes with experience and listening to babies and just assessing baby after baby, and eventually you'll know your sounds and you'll know what our lung noises and our stomach noises and our grunts. And yeah.
It sounds like a challenge for sure. Okay, so for those who are listening, is there any advice you have for them or last minute recommendations to either maybe find out if working with babies is good for them, or to just jump right in and take the plunge?
I would say if you like educating families, if you like working alongside families, a lot of my job is teaching, but a lot of it is just, getting through a day of, gaining weight. So it can be something as so small as to, I've seen, which is not in our scope, but, sometimes when a baby is intubated or it's severely unstable, these parents will come in and they'll just sit at the bedside, and the most they could have done is held that baby's hand that day, or they got 1 hour of skin to skin because their baby's intubated. And so it's getting through those days, but also you're working with them through educating and supporting, and you're not just dealing with a baby, you're dealing with so much more. You're dealing with somebody's grandchild, you're dealing with somebody's nephew, you're dealing with somebody's son, somebody's daughter. Very, very traumatic experiences come from birth, and I was so naive to that. I wasn't aware of the trauma that can happen even just during childbirth. Even some people will have trauma from the last delivery that they had, and then they come to the NICU on this delivery, and they've got, issues that are coming up from their last time they were at the hospital, things like that. So it's dealing with, a whole team of, what does this person need? If you're, you're dealing with social work, you're dealing with everything. And if you feel like in the midst of that you would love to just take care of a baby, then why not try? But it's so much more than just even just taking care of a baby. It's families and exciting, super awesome, exciting, happy times of welcoming this baby into the world versus being there for someone at the lowest point of they didn't expect to be in the NICU, and you're there to help them. So
You paint a really good picture. I love how you said, if you think caring for babies in the midst of all that chaos is something you want to do.
Yeah, like and you know, postpartum wasn't for me. I'm so grateful that I had, you know, that unit and those people and that experience, and that was awesome. It wasn't for me. But I do love the intensity. It is just a little bit more intense. I do like a little bit of adrenaline. You are extremely supported. There's always somebody to talk to, whether that be, you know, trauma that you had with a baby that you were dealing with, or, you know, something as so simple as you're just talking through an admission that you got. You know, it's a different breed, I think, or maybe it's just on my unit, but everyone is a family there, and extremely helpful. And honestly, I feel like the staff make it, and it's just a different breed of people, and I love the intensity of it. I love how it's fast paced, and also there's also slow paces of just being happy and being excited with a family member and sending a baby home, you know. So it's those moments that you still get the excitement of the babies, and it's all great, but also the intensity of dealing with math and breathing and vitals and tests and everything. So
everything, yeah.
Yeah.
I'm really glad you brought it and kind of finished off there with the supportive environment of the ICU. That's my experience too, being both a mom with a baby in there, but also working in the ICU is, to me, that's like the best place in the world to work.
Yeah, it's awesome. So
yeah. So thank you so much for joining us today on Frontline Nursing and sharing your journey and experiences through the NICU and your challenges and struggles and your wins. I think that's really important, and people get a lot from what you shared.
Thank you. Thank you for having me.
Now, if you'd like to hear more about Andrea's story and how she almost gave up on nursing and in fact took it off her resume, head on over to frontlinenursingpodcast.com and get in on that membership area for the behind the scenes conversations. And if you have a story you'd like to share, I'd love to hear it. Email me at info@tammydunnett.com.